My name's John Spurtis. I really want to thank everybody for attending today's QVIC forum. I know that a lot of other people are still sort of finding their way to the Zoom room, and nevertheless, we have a really packed agenda. So I did want to start, and I'm going to be filling in for often Stacy Farr, who's been one of the key leaders of the QVIC initiative, along with myself and Carol Decker leads this off and orients people to it. I'm going to step in today and do so. And we're also going to give a very brief introduction, but you'll get to meet her a lot more, Christina Pacheco, who's going to start taking an increasingly dominant role in helping to coordinate and organize activities around the QVIC. For those who are sort of a bit newer to our group and our network, the Kansas City Quality and Value Innovation Consortium is something that's spun out of the University of Kansas CTSA, which is an NIH Translational Research Award. And the goal and the vision was to bring multiple stakeholders together to improve the quality and value of healthcare in our region, really to try and translate evidence into practice to improve the way we deliver care and to lower its costs. We have sort of three main components to our activities. The first is regional quality improvement projects, and we have two, and as you can see, a broad number of hospitals in our region are participating in either the opioid or the KC EPIC project, trying to address opioid crisis in the ED, or transitions of care with a focus on heart failure. And today's presentation is largely a providing some context and an update on the heart failure project. It went in hibernation mode a bit with the COVID epidemic, but we've done a lot of work in the meantime, and we're going to reintroduce a lot of the tools and the concepts here to those of you who are participating. We also have a training component called Tiara. This was led by Ann Sales, an international leader in implementation and dissemination research, who's worked with a lot of our research team to have them think more rigorously about how best to implement new strategies to delivering care. And then finally, we have sort of a dissemination and engagement arm, and that's what this is, the QVIC forum, or an opportunity for us to share with you a lot of the activities that we're doing, but also to get feedback. This is a monthly conference that we have, and you can see some of our conferences from May here. Today, we're in the Transitions of Care for Heart Failure. And then in a month, we'll be having Regional Healthcare Quality and Value Landscape, which is going to be a very interesting presentation, including the Missouri and Kansas Hospital Associations, the Center for Medicare and Medicaid Services, hospitals, and other payers in the region. So we're very excited. But today, it's about heart failure. And as you know, there is a sort of a perpetual carousel of heart failure care. Patients who have chronic heart failure, they come to the ER when they're feeling worse, they get admitted, they get transitioned home, and they re-enter the pool of outpatients with heart failure, only to come back again and to cycle and cycle around. You know, the frequency with which this cycle repeats itself within 30 days in particular has been a real focus of Medicare, and it's been a very controversial penalty program, the Hospital Readmission Reduction Program, to challenge hospitals to lower their readmission rates. But it has forced lots of different strategies to think about ways to improve care. And we're not going to talk today about the challenges of that, but really about strategies to try and intervene. One of the most sort of common and well-tested strategies is risk stratifying patients when they're leaving the hospital to identify those at high risk for readmission, for which additional interventions might be offered, for example, such as telemonitoring. And I'm really excited to have Greg Fonarow, who is an international leader in heart failure and cardiology in general, and in quality of care in specific, who led a very large trial in California called BEAT-HF, and he'll describe some of what he has done there. Obviously, when patients leave home, there's a big challenge around the social determinants of health. Can they get to the pharmacy to get their medicines? Can they get to their doctor's appointments? Can they Do they even remember what meds to take? You know, is it safe for them get to be at home? What do they deal with food insecurity issues? And if we prescribe low salt diets and they don't have access to that kind of food, how do we challenge that? And so Paul is going to talk a lot, Paul Chan is going to talk a lot about a local effort, the Managed Services Network led by the Mid-America Regional Council, which I think is an extraordinarily novel strategy to address an aspect of heart failure care that we've never really thought about scientifically addressing with this kind of rigor and effort. And then we also, when patients show to the ER, who do we admit or not admit? Is there any rational strategy to doing that? And so Vital will touch briefly on the CODE-HF project that we presented in the past, but really about how to sort of lead and implement and get that going and what resources we have here. The only thing not included is within the admission space, within the hospitals, there's often a need to leverage the disease management programs of payers, the Blue Cross Blue Shield, Humana, United. And so Mary and Mark will be discussing better handoffs and coordination between inpatient services and payer disease management programs. So this is our agenda. I've talked as much as Stacy will allow me. Greg Bonnero will then be talking about the challenges in reducing heart failure readmissions and lessons they've learned from BEAT-HF and current thinking on whether they can be effectively and safely reduced. Then we're very pleased to have Leslie Curtis. She is a professor and chair in the Department of Population Health Sciences, the daughter of a Wichita couple we've been trying to recruit back to Kansas City for 15 years now. And she has an enormous platform and role at Duke and nationally in thinking about learning healthcare systems. It can provide some context for what we're trying to do with the QVIC. As I alluded to, Vital will talk briefly about the CODE-HF program and lessons that he's learned on the implementation of it. Paul will be discussing social determinants of health and the MSN program. And then Mary and Mark Patterson will be discussing the implementation and evaluation of coordinating payer disease management programs with hospital processes of care. And then we'll have more discussion at the end. So with that, I'd like to pass it off to Greg to start off. Thank you very much.
Great, thanks, John. I really appreciate this opportunity to join you to talk about a topic I've been very passionate about regarding heart failure readmissions. Can they be effectively and safely reduced? And what's the role of telemonitoring and other interventions? Here are my disclosures related to this presentation. So as alluded to, patients hospitalized with heart failure, there's a very high rehospitalization rate. 1 in 4, 1 in 5 rehospitalized within the first 30 days. Actually, by length of stay had been declining over decades. Rehospitalization rates had actually been rising. There's variation among hospitals. It was thought that many of these readmissions could be prevented and that there were strategies that could be utilized, but traditionally weren't being applied due to lack of financial incentives. And most of the costs, staggering cost of heart failure care, are related to hospitalizations and rehospitalizations. Now, a traditional admission for heart failure looks a lot like this: a little tune-up with diuretics, a little bit of education, discharging the patient on the exact same medications they came in on, wave them out the door and say, bye-bye, we don't want to see you back, at least in the first 30 days. But often patients would be rehospitalized and we'd see them back soon. Here's some of the data that was part of the rationale around HRP, where you'd seen the unadjusted 30-day all-cause readmission rates rising for Medicare patients and the tremendous economic burden. So 1993, it was a 17.3% 30-day readmission rate. By 2006 was up to 20.1, and 2010 up to close to 25%. But also I want to highlight the tremendous risk these patients face with regards to mortality. Fee-for-service Medicare patients, 30-day mortality rates about 11%, and 1 in 3 patients dying within a year. You go back to 1992, those were the stats. You go forward to recently, and they're every bit as bad. So you think about all of the therapeutic advances for heart failure, but for this patient population, they remain at very high risk for early as well as 1-year mortality. There is the variation in 30-day rehospitalization by hospitals, this by decile, and many speculated, oh, this type of variation has to do with the processes of care applied, and if we could take, those hospitals in the best performing categories and apply that strategy to care across all these hospitals, we could, cut readmissions pretty easily in half. But of course, it may turn out to be more complex than that. Now, for heart failure with reduced EF, we have a number of therapies that have been shown in randomized clinical trials to result in meaningful reductions in all-cause mortality with additive benefits of these therapies, respectable NNTs. And you'll notice that almost all of these therapies also result in meaningful reduction in heart failure hospitalizations. So at least in the context of clinical trials, we have a number of effective therapy, at least for the half of patients with heart failure with reduced ejection fraction. But we look in actual practice and how this is being applied in hospitalized patients, we see there are large treatment gaps that begin in the hospital and continue on an outpatient basis. And in fact, using risk scores, those at highest risk for mortality or readmission are paradoxically less likely to be treated. So our treatment gaps that begin in the hospital continue on an outpatient basis, at least through the first 90 days, and those at highest risk for readmission mortality, paradoxically, even less likely to be treated. So there's some opportunities there. With the ACA, the HRP program was launched presumptively on this basis if hospitals were incentivized to prevent preventable readmissions, that they would be able to readily accomplish this. So it uses penalties, but notably did not provide hospitals with any effective strategies to actually reduce readmissions. A major driver here is heart failure, and this has been a lot of the focus. But the challenge, of course, would be, okay, we're incentivized to avoid these penalties for early preventable readmissions. How will we actually go about that? So the challenges here lie up in not all rehospitalizations are preventable, and importantly, not all rehospitalizations are unnecessary. There are some patients that are going to be harmed if you block that early readmission because they would be better off in the hospital with their early exacerbation. Many of these are not for heart failure, but are related comorbid conditions. There are often multiple care providers, so how to coordinate that care. And of course, other outcomes. Patient's health status, critically important in this regard, as is survival. It's not just about rehospitalization. There are unique patient-related challenges, multiple comorbid conditions, frail, cognitive impairment, can have limited social, financial caregiver support. And there are a lot of transitions going on as patients move from hospital to home. And these slide lists some of the breakdowns that can occur. Now, some of the concept with enhanced transition of care or telemonitoring, we could potentially make up for some of these opportunities for the breakdown in transitions, enhance care, presumptively preventable readmissions, and improve quality care and outcomes. Now, if we look at the evidence-based support about what has been shown to actually help in some settings reduce 30-day rehospitalizations, this is really what a literature search shows. Certain guideline-directed medical therapies and pre-discharge use of them can reduce hospitalizations, pre-discharge intensive heart failure education by trained educators, discharge med programs, comprehensive discharge planning, early post-discharge physician follow-up, home RN visits can also in some settings help, comprehensive heart failure disease management programs, and at least implanted hemodynamic sensors. Telemonitoring, the data is mixed. I'll show you some of the recent larger trials. But I do want to highlight that if we look in the clinical trial setting, this has been replicated in real world evidence settings as well. For heart failure reduced EF, the guideline directed medical therapies, when started prior to hospital discharge have really a remarkable impact on the composite of cardiovascular death and heart failure hospitalization, not in months, but in the first few weeks. So data even in severe heart failure with recent exacerbation with beta blocker therapy in 2 weeks, those survival curves have diverged. With aldosterone antagonist, we see benefits within the first 30 days. The data from Pioneer compared to being discharged on an ACE inhibitor, being discharged on sacubitril valsartan, a 6% absolute risk reduction in the first 8 weeks in clinical events, and the newest SGLT2 inhibitors also having major benefits, CV death, heart failure hospitalization, first 28 days from initiation. So we actually have a nice cadre of medications that can reduce 30-day hospitalizations when they're applied, and also have intermediate and long-term benefits with regards to mortality. So this needs to be an essential component, at least for heart failure reduced EF, as part of our management programs. And there are a number of studies looking at applying this. This from Intermountain Healthcare. 10 hospitals at the time had about average rates of ACE inhibitor ARB use, had a pre-discharge checklist to make sure everybody that was eligible was on an ACE inhibitor ARB, improved, and there was a reduction in readmissions as well as 1-year mortality. Yeah, with the guideline heart failure program is from the AHA and used electronic case report form to capture the data before discharge. You could interactively check patients' care with the guidelines, and the use of this has been associated with lower 60 and 90-day mortality and rehospitalization. So you improve the processes of care, utilization of the appropriate medications, you can have some impact on early outcomes. For other strategies that have been utilized, this is Mike Rich data with home visits for older heart failure patients, and you can see there was a reduction in readmissions within 90 days. Pretty intensive type of program, but did have benefit for these patients. There's some additional interventions that have also been associated with better outcomes, providing before the patient leaves their full 30-day supply of medications, prepared meals. There's some early data having patients attend group classes in the first 30 days post-discharge. There's some others you could question a little bit about, use of observational units to keep patients out of the inpatient reclassification. That may be appropriate, but could also be a form of gaming. And there were at least a few centers reporting actually paying money to patients to stay out of the hospital for 30 days. I wouldn't necessarily endorse that. Now, as part of the Hospital to Home initiative for the ACC, they did an extensive survey of strategies hospitals were utilizing to reduce 30-day readmissions. And these are the ones that were associated with lower risk standardized rates. But I'll also show you this. When you look at hospitals using only 2 or 3 of these versus all 8 or 9, the absolute difference in readmission rates were incredibly small. So no one strategy is going to be sufficient here. And even when using all of them, the benefits associated with that were really modest. And when we looked at this, Get With The Guidelines, extensive survey using mixed methods on 100 hospitals, looking at 6 major domains of care and over 100 survey questions, we really found very little association with the distinguishing performance for hospitals. So this is challenging. So now let's look at telemonitoring. So the first large randomized study, Chowdhury and colleagues, Krumholtz was involved with this, visual care versus telemonitoring. They started a few weeks after hospitalization for heart failure. You can see for the primary endpoint, really no difference here. Now they did find there was a pretty rapid drop-off. Adherence rates were only around 50% with the use of the telemonitoring. So with BEAT-HF, we thought we could improve on this. Started in the hospital, patients were trained on their telemonitoring. They were supported with a 24/7 call center that could be utilized. We're monitoring weights, pulse oximetry. All patients were explaining units, were receiving regular phone calls to enhance adherence regarding the use. This was the UC Hospitals and Cedars, and a well-powered study. And you can see here, really, we had no impact on clinical outcome. Now, the focus here was really on those transitions of care and home monitoring and not necessarily the medications. We did, despite all the efforts, have only about a 60% adherence rate. Those that did adhere with telemonitoring did seem to derive some benefit, but that's all post hoc. And again, another large multi-center initiative where, thinking this would work out well, surprisingly for every endpoint, really did not find an associated benefit with this strategy. More recently in Canada, this patient-centered structured transition of care program. So here in a healthcare setting where there was access, you can see all the steps they took with patients. You would think this would have been an effective initiative, giving them really intensive follow-up in this period of time. And yet you can see it through the first 90 days with the intervention versus usual care. But what I would highlight in both BHF and this initiative, the medication regimen was really left to the individual physician. There was not that attempt, other than having patients adhere to the therapies they were on, rather than actually trying to get them on each of the key evidence-based therapies. There are strategies to try and select higher risk patients using validated risk models or biomarkers, or just intensive management of all patients in the first 30 days that also can be considered. So I want to say one thing about the HRP in the national level, and that is, there have been great incentives that have been offered to hospitals to try and reduce 30-day readmissions. And there are a number of patient-centered strategies that could reduce readmissions, that should decrease ER visits, OB visits, be at least neutral on mortality that are shown here. But there are also some non-patient-centered strategies to reduce readmissions that are more gaming and could be harmful. So upcoding, discouraging patients with worsened symptoms from seeking attention, blocking them in the ER even though they need to be readmitted, shunning patients that would be better managed inpatients to OBS units, and delaying use of evidence-based guideline-directed therapy. If this was done at the national level, we'd expect readmissions to go down, ER visits, however, to go up, OB visits to go up, and worsen mortality. And actually, in the first period of HRP, what actually happened nationwide is exactly the non-patient-centered strategies. Readmission, inpatient went down, but ER visits unplanned in the first 30 days actually went up, OB visits went up, net returns did not fall, and mortality went up. So the lesson here is we really need to focus not on gaming, but truly patient-centered strategies. So this slide shows some key takeaway points in this brief presentation. Beginning from the moment the patient's hospitalized, what are we going to do differently? Optimizing their evidence-based meds, pre-discharge heart failure education, comprehensive discharge planning right away, early post-discharge follow-up for higher risk patients, comprehensive disease management, when appropriate, consider palliative care services, and system of care approaches like joining GO with the guideline heart failure. So there are a lot of opportunities to improve the quality of care, transitions, and outcomes for this high-risk population hospitalized with heart failure. Certain strategies have been successful, but others have not. Hopefully we can learn from them. And certainly we need new approaches and strategies to improve outcomes, but including patient health status, as well as longer-term survival in this population. Thanks so much for your attention.
Great, thank you, Dr. Fonarow. So now I just want to remind everyone, we're going to do a Q&A and after our next speaker, a brief Q&A, and then we'll have another Q&A at the end. So please do submit any questions you have to the chat box, or be ready to ask those of either of our two speakers after our next speaker. So now I'll turn the mic over to Dr. Leslie Curtis, who we're privileged to have. She's going to speak about transitions of care and the role of learning healthcare systems. She is professor and chair in the Department of Population Health Sciences and professor of medicine at Duke University School of Medicine. So the floor is yours, Dr. Curtis.
Great, thanks so much. It's really a pleasure to be here today, and I'm going to apologize in advance for the light in my office that keeps going out. So if I suddenly seem that I've gotten very dark, that's the explanation. It is a pleasure to be with you today, and honestly, a real personal pleasure to follow Greg Fonarow in this topic. He certainly laid some really terrific groundwork for the comments that I'll make, and because I know a brief presentation, it can be challenging to sort of pick the main point. I'll give it to you at the beginning, and it is rigorous evaluation is at the heart learning healthcare systems. And I may be preaching to the choir given the introduction that John gave to the work that you all are involved in, but you'll see by the end what I mean. Greg really nicely laid out how complex the transitions of care are in heart failure, and moreover, that elusive magic bullet that we want to find to help us reduce readmissions, it's elusive. I knowing that I would be speaking after Greg, I pulled up actually a paper to illustrate this point. And this is a long time ago now, 10 years or so. We empirically analyzed the association between early physician follow-up after hospitalization with heart failure to see whether or not that was associated with improved lowered 30-day readmission in Medicare beneficiaries. And we found, sure enough, that it was, right? So patients who were discharged from hospitals that have higher early follow-up rates had a lower risk of 30-day readmission. That sounded like a great intervention. And I would say on the basis of this work and other work, many began to adopt this as an approach to reduce readmissions. Well, in Greg's talk, I didn't realize that he would be talking about this, but he highlighted the paper that really tested this in some ways directly. Although, as he noted, in the PACT-HF trial, they actually looked at a much more complex, multifaceted intervention. But that intervention included physician follow-up appointments within a week of discharge. And as you know from his talk, they found there was no association. There was no significant association. Now, what's the takeaway here? Well, the takeaway is that when we don't use randomization, right, when we use just observational studies for these kinds of insights, they may give us insights and hints, but until we do the formal, rigorous evaluation, usually with some form of randomization, we're really kind of shooting in the dark a bit. And I would further just highlight that really much of what we do in healthcare isn't put to the test, right? And there are all sorts of examples of this. I think maybe the most the one that comes to my mind most recently is the work that was done out of New Jersey by the Camden Coalition of Healthcare Providers. And you all may remember that this was the group that looked at hotspotting as a way to really identify patients at high risk of high cost patients so that they could help them stay out of the hospital and help them stay healthier. It was widely described, anecdotally reported to be very successful. And in fact, their anecdotal and the data that they collected observationally was very strong. And then earlier this year, as they should do, not earlier this year, but they put this to a test in a randomized trial. And Amy Finkelstein and her colleagues wrote the summary of that, which showed that actually that approach did not have a demonstrable effect on the outcome of interest. So I put these two examples before you, or more than two examples before you, really to lay the groundwork for what is at the heart of a learning healthcare system. And I told you at the beginning, it's rigorous evaluation. So let me sort of walk through and give you some examples where that's being done at a local level, and then touch on where that's being done nationally as well. So, I love the Institute of Medicine's definition of a learning healthcare system, because it really highlights this notion that a learning healthcare system, it's not just about one thing, right? It is about science and care and evidence coming together, but those incentives, the culture, the leadership within the healthcare institution has to be there as well. And not surprisingly, from the punchline that I gave you, I think it's really important that learning healthcare systems, we recognize that they are constantly generating new knowledge, and that new knowledge is captured actively as a byproduct of healthcare delivery. So it's not something that learning that these healthcare systems do just in their research arm, right? Rather, it's something that is embedded in the way that care is delivered. So John had suggested that maybe I provide some reading in advance, and I gave to you all this, what I think is really just a terrific example from Leora Horowitz and her colleagues about what they have done to create a learning health system through rapid cycle randomized testing. I had the pleasure of interviewing Leora. It's been several months ago now, and you know what? As I talk about this, what was really striking to me is that I asked her sort of what was the initial investment in the infrastructure to make this work, and if memory serves, they had a donor who gave like $150,000, maybe $200,000 to get this running. And because of the way that they've focused their efforts, they've had the opportunity to identify places where they are doing things that don't benefit patients, don't benefit the healthcare system, but things that they've always done. They could de-implement those and take those cost savings and shift them into the next study. So it really so far appears to be quite a sustainable model as well. So if you had a chance to flip through this paper, you noticed in the first table some of the examples of the randomized QI projects that they'd performed to date. And you know what was striking is that many of these, as she described them, many of these were things that they'd done for a long time. People were absolutely sure they worked, and so they said, "Well, let's test it." They did, and pretty quickly found out that maybe they don't work. Right? Maybe there are things. Maybe we don't need to be doing those things. Maybe we should be looking at other things and testing them. You know, just to sort of summarize, I would say some of the key attributes of those successful projects from her perspective and from the team's perspective. Not surprisingly, engagement of frontline clinicians is absolutely essential, right? And furthermore, you have to choose the right kinds of questions and intervention strategies to test. It needs to be in a place where, in a setting where the standard of care is established. You have to have really a high volume of cases, and otherwise you can't really get to that rapid cycle learning that really makes this sustainable, nor can you do it within a single health system, which really is what this rests upon. You have to have some kind of feasible randomization strategy, right? Sometimes that might be individual level, but more often it might be clinic level, right? So you might have groups that you are randomizing. You might also use almost a pseudo randomization strategy, right? Where you do it on the basis of a medical record number or some other pseudo random characteristics. And then also importantly, that the short-term outcome really has to be of high interest, and it should be something that's already collected as part of care delivery. Short-term is important because if you're doing rapid cycle, you need to get to the answer as quickly as possible so that you can move on to the next thing. So that was a great example of how you might do this in the setting of a single institution. For this group, though, I think one of the key questions is, how do we think about doing this across institutions? And here I just want to call your attention to work and resources that have been done and sponsored by the NIH for almost a decade now through the NIH Healthcare Systems Collaboratory. I have the pleasure of serving as one of the PIs of the Coordinating Center for the Collaboratory, and it's all about generate how we can learn about how to do what we call embedded pragmatic trials more efficiently, right? What are embedded pragmatic trials? they're exactly the kinds of studies that I described that are at the heart of learning healthcare systems, right? So they are trials that are embedded in healthcare delivery across healthcare delivery systems. And in fact, for collaboratory projects, all of these, it is a requirement that they span multiple health systems so that what we learn about these embedded pragmatic trials, we learn in a more generalizable way. That is, the learnings come from multiple healthcare systems. You know, and these, just to maybe describe this a little bit more, these trials really do cross that bridge between research and clinical care. So the studies are designed with input from the health system stakeholders. Oftentimes data come directly through the EHR, not always, but always the outcomes are important to decision makers. And in fact, those healthcare system leaders are often engaged at the very beginning when the study is first designed. So the question is, what is the most important outcome for you in this? What can we demonstrate that will inform your decision making and your actions? The interventions are always incorporated into routine clinical workflows so that, again, we're not talking about that separate parallel infrastructure for research and care delivery, but those are brought together. And the study populations are diverse and represent the people, the patients who ultimately will benefit from what is learned. So that was a sort of a breeze through of a couple of examples of how learning healthcare systems, I think, really bring value to, or that concept brings value to these kinds of efforts. And again, just want to reinforce that it's that rigorous evaluation and finding out exactly what works and what doesn't that is truly at the heart of learning. So with that, I will thank you and look forward to the Q&A.
Great, thank you so much. Is there anyone on who asked a question in the chat box that would like to ask theirs aloud? We have about 10 minutes, so we could start. I see Sarah Sanders or Vital have a question. Otherwise, is there anyone else on who would like to?
This is Sarah Sanders. I don't know. Can you hear me?
Yep.
Hi, thank you so much. Presentations are just fantastic, and I appreciate being able to listen in today. I just had a question in terms of some work that I did during my graduate days in my DNP. You know, a lot of nursing research has been focused on looking at, self-care and management of patients with chronic diseases. And a lot of, focus has been looking at heart failure. And, when we look at some of these trials that Dr. Fonarow, alluded to, I just curious if, there was any consideration to be looking at the social determinants of health and evaluating the impact of those issues for a lot of patients. And I just speak to that anecdotally from my clinical practice and things that I've seen over, my 20 years in nursing. What is there anything, is there any data or was any of that considered in looking at some of those post hoc analysis?
Yeah, so let's start, terrific question. No question that social determinants of health are absolutely critical here. There's a wealth of literature regarding health literacy, socioeconomic factors playing a big role in readmission. So no matter how you look at it, some of the interventions have been designed around trying to factor that in and having the ability to try and make those assessments and address patient and their caregiver needs. The real question is how efficacious have those interventions been? So BeAT-HF did do an assessment of patients before they left and tried to develop in a culturally sensitive way the patient education materials and having diverse group of clinicians to interact with the patients, but that wasn't ultimately successful. There have been some randomized trials that have looked at self-care that have been done for the general heart failure population, but there's also one targeted for more the rural population that was challenged, and self-care alone, education did not seem to be sufficient. It may be a necessary component, but one that in of itself didn't really lead to less hospitalizations or improved outcomes. So a lot more work needs to be done here. There's a movement towards trying to have assessments of the social determinants of health better embedded and available to clinicians through the electronic health record. So I think a lot more can be done here.
Yeah, thank you. Thank you for that.
Hi, this is. Oh, sorry, go ahead.
Sorry, go ahead. I was just going to ask a question, Dr. Faunereau. Thank you for that presentation, and for Dr. Curtis. That was a great presentation from both of you. I was really disappointed to see beat heart failure and PAC heart failure not showing what it did. So my question really was, do you think that telemonitoring itself has any kind of impact, if at all, on medication adherence itself? Because we know that heart failure patients you showed in your presentation that medication adherence plays a huge role. So do you think telemonitoring is beneficial for that?
So I think there's the potential there. The intervention really was around supporting the medications that the patients were on by their clinicians rather than trying to improve those. And so at least in that sense, so the kind of treatment gaps that we commonly see, they were also present in the BHF patients. For the meds they were on, we didn't detect a difference in adherence, but it was really left to their clinicians as to what meds they were on. So I think there is still potential there. There is a recent publication, JAMA Cardiology, where actually remote navigators were used to try and up-titrate guideline-directed medical therapy. And for 2 or 3 meds, there was improvement in use and improvement in dosing with that. So I do think there are additional interventions that we could test, and I kind of alluded to it, but we do ultimately need to prove that in randomized trials to demonstrate that scalable, sustainable, who benefits the most. But I really think there is some potential there, but the traditional telemonitoring of daily weights being transmitted in this other data, I'm more skeptical about, because there have been a number of these trials where it hasn't worked.
Thank you.
Hi, this is Aditi from KU Med Center. I had a question about embedded pragmatic trials. So, we want these trials to be pragmatic so that we can look at the real world scenario. But then when we have this issue of consent, and consent in these trials often extends to patients as well as physicians, because sometimes if you are trying to randomize physicians and get their surveys and things like that, and I feel that sometimes those factors can change the patient population slightly. How do we deal with that problem? Like, do we, each IRB might have a different perspective of whether a consent is needed or not. And when you're trying to do a study across different centers, how do we deal with this problem?
Yeah, that is an excellent question. And very early on in the life of the collaboratory, we realized that some of the most important work to be done was actually around the ethics and regulatory issues, right? That every investigator, every institution experiences, right? And as you say, you experience it differently depending on which institutions you're dealing with, and sometimes depending on maybe which IRB reviewers within the institution you get. So it can be really challenging. Maybe to just make sure that I direct you to some of the resources that are available in the Collaboratory Living textbook around these ethics and regulatory issues specifically, and approaches that these trials have taken to, I would say, create more of a glide path within their institution for these kinds of studies, articulating how to get how to help IRBs understand minimal risk and how minimal risk might apply in the context of an embedded pragmatic trial. So it really is an excellent set of resources. But you're absolutely right to say that that is something that you have to think about very early on, because it is often not possible to do these. It's often not possible to do patient level randomization without a waiver of consent, unless your IRB has a fairly, I would say, broad perspective on that. But I would direct you to the resources. They're truly excellent.
Great, thank you. That fed right off of my question too, which was about the same exact thing. So Aditi and I were on the same page. We have a couple more questions in the chat box. Kim Fuller, Kelly Bosak, if you would like to ask them aloud, I'd certainly give you that opportunity.
Sure. Hi, this is Kelly Bozak. I was walking on my treadmill, so I thought I'd just put my comment in the chat box. But I've stopped now, so I can certainly ask it. This was directed to Dr. Fonarow, and I was just wondering. You showed some percentages of heart failure admissions increasing over the years. I was just wondering what you think is behind that. If, we know the population with heart failure is growing, and if that has anything to do with it, or how you might explain that.
Yeah, it's a great question. And the national level, it obviously gets complex for multiple factors. Actually, the good news is the number of heart failure patients total has actually somewhat decreased as far as new onset heart failure. So we've gotten better about cardioprotective meds with MI and other types of patients. So there has been that decline, but the patients with heart failure onset, as far as their survival and their hospitalizations and rehospitalizations, we've really not made a lot of progress there. And then, unfortunately, after the hospital readmission reduction program, if anything, some of the adverse type of strategies that were applied, if anything, we've seen mortality in the first 30 days and even beyond going up slightly. So, these gaps in the use of the evidence-based medication, not just in their use, but also the optimal dosing, has really contributed in many ways. Some of it may be the pressure by DRGs to keep length of stay short. Some of it is, there's pressure to have patients go to these alternative settings in home, like skilled nursing care facilities. And if you look at the outcome of those patients, as far as readmissions and mortality, very, very poor, and underutilization in appropriate patients regarding, hospice, either at home or facilities. So there's a lot of complexity there, but a large driver here is where we have evidence-based therapies, they're really being substantially underutilized. So removing those barriers, I think, is going to be really important.
Okay, thank you.
I think you might have answered my question, because I had asked a question about patients who are discharged to SNFs and whether the care at the facility was a material factor in readmissions, which is what we have found, that there's a lot of inconsistency in their understanding of heart failure and what happens in the middle of the night when, a patient's having a problem, and whether they end up at the ED or, can be managed at the SNF. So I think you addressed that it's not always good.
Yeah, I'll just emphasize that. It's shocking what the outcomes were when we looked at it and get with the guidelines for first time. Larry Allen was the first author on that publication. And so much of it is what you just explained. We'll see where the heart failure medications the patients discharged on are being discontinued because they're viewed as antihypertensive medications and their blood pressure is 100. Why are they on this med? They get stopped, get high sodium diet. So all of these things that go on in those settings, but you realize there hasn't been guidelines offered, training, there's variability even with home nursing. So we've got a lot of work to do, and there are health systems that are reaching out to their skilled nursing care facilities, home nurses to try and improve that heart failure education and care in a coordinated fashion. So that can be an opportunity to think about.
Thank
I
you.
had one quick question, Dr. Curtis. We have a lot of different sort of centers in the same region. In some of the collaboratories, have there been challenges? If you have strategies to suggest to overcome a inherent unwillingness to share data so that you could do the rigorous evaluations that are necessary to figure out what's working and what isn't?
Well, so the NIH mandates data sharing in order to receive the funds from the NIH. So that's a pretty big stick, right, for institutions who are participating. They have to share data in order to get the money.
Right, but we're not in an NIH-funded
Right,
trial,
exactly.
right? So we're trying to build trust and collaboration in the real world, and so
That's right. That's right. And so with that, I think it is all about that, showing it is building trust, building the relationships, and demonstrating how you can use data together to improve the way that to inform care, to inform the way that you're delivering care, and not also use it to compete against each other, right? But it's such a trust issue. No magic there.
thanks. Well, I think that we should, I mean, look, we could spend the whole time just having a discussion with the two of you. We're so appreciative of you taking the time to participate. You're more than welcome to hang on, but we know how busy you are. And we've certainly benefited a lot from your experience and wisdom. And at this point, we'd like to shift to some of the next stage of presentation. Is that okay, Stacy?
Yes, thank you. And so our next speaker is Dr. Vital Hajaji, who is a fellow and has been working with the KC Quality and Value Innovation Consortium, and he's at the University of Missouri, Kansas City, and St. Luke's Health System. He'll be talking with us about improving outcomes for heart failure patients, lessons learned from the emergency department initiated Code HF. So the floor is yours, Vital.
Thank you. Thank you, Dr. Farr. So again, thank you for the opportunity for me to present our work about the Code Heart Failure Project, which is a quality improvement initiative within the emergency department. And I'm pretty passionate about this project that I've been working on for the past 2 years. So you all saw this with Dr. Spertus's introductory presentation about the course of a heart failure patient. And we know this, that the unfortunate carousel that heart failure patients often go through. And Dr. Faunereau clearly talked about all the interventions that's available at this time to kind of break the transition cycle, risk stratification methods that's there just before being discharged from the hospital, including the CMS model, the LACI model. What we at St. Luke's and at the UMKC tried to plan to do was to try and attack this particular transition cycle at an earlier time point and try to see if we can risk stratify patients at the ED level just before they're being admitted to the hospital. All the more important to do this, with the ED visits growing every year, as Dr. Faunereau's presentation showed with the implementation of the HRRP. However, there are multiple challenges within the ED. The emergency department is a more complex environment as opposed to an inpatient or an outpatient setting. It involves multiple stakeholders like physicians, triage nurses, and bedside nurses who need to work together to bring about a change or an intervention. And triage in itself is an imperfect science, more so for acute heart failure because the symptoms mimic that of COPD exacerbations and pneumonia and other common respiratory diseases. However, the first question we had to ask to try and build this ED-based intervention is, why would anybody want to admit an acute heart failure patient? What is the main reason of admitting these patients? One is to obviously prevent death in critically ill patients. Two is to make them feel better. Symptomatic relief is extremely important. And lastly, to try and identify why they had an exacerbation in the first place. So the next question we had to ask is, are there patients out there who come to the ED who could potentially be discharged directly from the ED And if so, who are these patients and what are the characteristics of these patients? One is just to see if we can somehow find out if they have a low risk of dying in the near future, if the patient feels better within the ED, if there's symptomatic relief from the interventions provided in the emergency department, and if there was a very obvious reason as to why they had an exacerbation. Medication adherence is a big deal for heart failure patients, and so if that's been identified, and if we're able to establish early outpatient follow-up for these patients, then potentially these type of patients can be discharged from the ED in an evidence-based manner without having to get them admitted to the hospital. On that background, we built the code heart failure pathway. So with any patient with a documented history of heart failure, not new onset, but known heart failure, coming in with a chief complaint of shortness of breath, gets treated through a code heart failure order set that's built into the EMR. And the order set has a risk calculator that's embedded into it. It's called the EHMRG risk score, emergency heart failure mortality risk grade. It's been well validated and prospectively validated, developed up in Canada. And it basically gives the risk of dying for an acute heart failure patient within the next 7 days. Now, if that patient has a risk of dying of 1% or higher, we decided that these patients need an admission and get admitted to the hospital. If it's less than 1%, they're observed in the ED for symptomatic relief after the intervention of giving IV diuretics. If the patient doesn't feel better, they get admitted to the hospital. But if they do feel better, then the physician talks to the patient's family members, and tries to see if the patient can be managed as an outpatient and be discharged from the ED. If for some reason the patient needs to come into the hospital for other causes, or the physician feels that the patient needs to be admitted, they get admitted to the hospital. If not, they're discharged directly from the ED, and we also built infrastructure to provide heart failure education within the ED, and also made sure that they're followed up in a cardiology clinic within 7 days. And this put together formed a care path for heart failure patients coming to the ED. Our findings after implemented across the St. Luke's Health System over the course of 1 year was recently published in the Circulation Cardiovascular Outcomes Journal. And mostly over the course of 1 year, we showed that we were able to reduce the number of hospital admissions, or in other words, increase ED discharges from all 4 major metropolitan hospitals by about 50% relative increase. Most importantly, we were also able to reduce the length of stay within the ED by about 54 minutes, making the process of triaging these patients more efficient. And we also reduced the number of inappropriate admissions. That are admissions, we said, that had a length of stay less than 48 hours, that op status admissions by about 20%. But however, implementing this and designing this itself was a task that needed a structure to it. As an implementation research, we used the WeAIM framework to try and design our implementation process. The first thing we did to try and make sure that our target population has, that the AD physicians and nurses, have access to our intervention, we integrated this into the EMR, mostly the risk calculator, the EHMRG risk calculator, into the electronic medical record. We built infrastructure for heart failure education that can be provided within the ED. And then we assessed its effectiveness. Like I already mentioned, we were able to increase ED discharges for acute heart failure. We reduced admissions that were less than 48 hours, reduced time in length of stay in the ED. And we, for adoption across the health system, which was implemented across 4 major metropolitan hospitals in Kansas City, we obviously needed organizational support, and that's exactly what we were able to establish. We were able to put about standing orders within the ED and best practice alerts, which really helped us to move this forward. And to ensure smooth implementation, we had bi-monthly meetings within the Code Heart Failure core team. We talked to ED champions, nursing champions, and physician champions, and talked and troubleshoot any problems that came about. And now we're at this maintenance phase, the last phase, where we're trying to further improve adoption, but at the same time, collect more data into seeing if our initial findings of how effective these were can persist over a longer duration of time and go forward. So together with the CODE-HF, we found that it has great initial success. It uses validated models within the ED. It increases discharges from the ED, which we were able to achieve, reduce unnecessary admissions, that were admissions that are less than 48 hours length of stay, shorten time in the length of stay in the ED, shorten time to cardiology follow-up, outpatient follow-up after being discharged from the ED. And put together, we think that code heart failure is something that a quality improvement initiative that can definitely be adapted at other health systems to improve the triage of acute heart failure patients in the ED. A few things to remember for those health systems that are thinking of adapting code heart failure within their system is to identify champions. This is obviously a teamwork that needs to be done. It's no one individual. And champions should involve both clinical champions and administrative champions. Both required to move this forward. And to integrate the whole project into daily workflow is extremely important to make it more efficient. The most important thing is to use the electronic medical record to build the risk score, which is the EHMRG risk score. For those hospitals that use Epic, the St. Luke's Health System is more than happy to share the way we built it, and our group, the QVIC, is able to help the group to build this within Epic. For Cerner, we just finished talks with the Cerner team to build this within the Cerner database, and also are piloting this at Truman Medical Center. The QVIC team can also help health systems to made a system-wide launch of code heart failure for those health systems that are interested. This is the entire team of code heart failure led by Dr. Spertus across the health system. Like I said, it's a multidisciplinary effort that took place, and we think that a lot of work needs to be done going forward. Happy to help other teams who are wanting to implement this at their health systems. Thank you.
Great. Thank you so much, Dr. Hajaji. Any questions for him can be dropped in the chat box. We're going to get to the Q&A later, and we're going to move to our next speaker. So now we will be hearing from Dr. Paul Chan, who's a cardiologist with St. Luke's Health System and professor at UMKC on addressing social determinants of health with the Managed Services Network. The floor is yours, Dr. Chan.
Sure. Thank you, Stacy. And thanks for everybody for staying on this 90-minute conference on the QVIC. So I am going to talk about an innovative program that has been put into place. This is a program that we have not developed, I just want to clarify, but that we're hoping to implement and study as a pilot in some of the Kansas City hospitals within the QVIC. It's called the MSN, or the Managed Services Network, and it's run out of the Mid-America Regional Council down on 6th and Broadway. So as many of you know, our healthcare system is facing a lot of transformational changes, and the rapid growth in the number of older adults is already straining the capacities of hospitals and of providers, and the need will only grow. And the coming shifts to value-based reimbursements may also alter the financial foundation of many healthcare providers. Importantly, a new understanding of the social determinants of health and how it impacts health outcomes has greatly increased the focus on non-medical community supports, and especially with conditions that afflict the elderly in our discussions today, congestive heart failure. Now, the Managed Services Network has come up with a solution after more than a year of deliberations and research and exploration and meeting with Kansas City stakeholders. They've determined that one of the best ways to address the concerns of patients that are not medical is through a coordinated network of community services that are oftentimes outside the reach of many of our patients. Like other networks across the nation, the MSN, or the Managed Services Network, will be a community asset and will help improve health outcomes for patients in the end. And along doing so, the goal is for the MSN is also to reduce costs for insurers and hospitals and other stakeholders. And at the end of the day, achieving what is most important for our patients in improving their outcomes and also increasing their satisfaction. Just to give you a sense, some of you have heard me talk about the MSN before, but for some of the people here on the call today that this is new, this is how the MSN is conceived to operationalize. Hospitals, when they're taking care of patients prior to discharge, and certainly insurers, can identify patients who have high needs from an economic standpoint, from a food security standpoint, from a housing security standpoint, things that are not specific to the medical care, but really impact their ability to focus on the medical condition once they're discharged. There are a variety of community agencies that already provide services today for our patients. There are services that deal with community-based care management. There are community organizations that provide transportation for patients, as well as meals and nutrition assistance. However, oftentimes, even our patients who are poor and at the highest risk from a social determinants of health standpoint do not have access or do not have the right connection with these referrals for these programs and do not, as a result, benefit from them. So how can you ensure that patients transition to the services that they need once they leave the hospital? This is where the MSN comes in, and they are conceiving themselves as the go-between to ensure that the connection that we identify when patients are in the hospital from a social determinants of health standpoint get met. Hospitals will send the MSN a referral, and it's a one call, one referral to the MSN itself rather than multiple referrals to community agencies. The MSN, in turn, will provide coordination of these services as well as ensuring additional referrals, when identified, are made to other social organizations. They'll do billing and reimbursement and also meet performance standards. In turn, the MSN will provide feedback to hospitals that they receive the referrals from to inform the hospital stakeholders about the services that their patients receive. The goal of the MSN is really to provide food security, transportation to all physician appointments, housing referrals, and utility assistance as needed, depending upon what is identified as part of the need. When the MSN gets a referral, prior to the COVID-19 pandemic, they would do a very detailed intake home visit with the patient to really identify what those needs are and whether and how best they can serve the patient. Post-pandemic, they're doing this as a video call or a detailed phone call to really do the intake that they normally would do in person. And what does the MSN do and at the end of the day for our patients with congestive heart failure? First and foremost, their goal is to meet the social determinants of health needs of patients so that they can then focus on their heart failure first and foremost when they leave the hospital, and not whether or not they can make the next rent payment or the utility payment, where they can find their next meal, where they can find meals that are low sodium. The MSN is envisioned as a simple referral, one referral to the MSN. They coordinate the services rather than hospitals and social workers trying to negotiate multiple referrals while the patient is in the hospital and not knowing whether or not their patients have connected with the referrals after discharge. The goal for the MSN from the hospital standpoint and from the patient standpoint is to reduce readmissions and ultimately to improve health status. But from the hospital stakeholder and payer stakeholder perspective, it's also to reduce the Medicare penalties that are for heart failure, which is one of the 3 conditions that meet that penalty. And ultimately to engage hospitals and payers to have a seat at the table to help envision and create a new and dynamic healthcare system where it's collaborative and where we engage in the non-medical needs of our patients. And it's envisioned, the MSN believes that by doing all of these services and these interactions with social service agencies on behalf of patients, this evidence-based program delivery will is believed to save 10% in costs at the end of the day and provide a return on investment to payers, to hospitals, to patients. But by also providing and meeting the needs of food insecurity, transportation access, the MSN believes that they can actually increase that amount of savings to up to 20% of healthcare costs. I'm not going to get into this. This was designed by the MSN itself, but this is sort of a design framework as to how they will operationalize the types of resources that are required, the types of activities, and the types of short and long-term outcomes that the MSN can potentially realize in the lives of patients with heart failure. And in talking with the MSN initially, they had thought about a couple of ways to implement the referrals to study whether or not the MSN actually improves patient outcomes or reduce hospital costs. And I'll get into this in a little bit. So what we've done is have had a number of meetings with James Stowe at the MSN and with hospitals in the QVIC to gauge their interest as to whether they would be interested in incorporating the MSN for their patients at high risk for readmissions from a social determinants of health standpoint. And that process has included identifying patients, figuring out who is going to identify patients at high risk from a social determinants of health standpoint at the hospital, developing a screening tool in consultation with the MSN. And the first hospital we've been working with is the St. Luke's Hospital in the Plaza, so the team there. Developing an understanding as to who would send the referral from the hospital, St. Luke's, to the MSN when a patient is identified to be high risk. We've developed a one-page flyer that is informative and up to an 8th grade literacy level for our patients. And also made sure that we have the infrastructure to follow patients up to 90 days post-discharge to better understand the impact of the MSN on readmission rates for our patients. I see that I'm running out of time, but suffice it to say that we thought of different ways to study the MSN, and we have decided that the best way, and as Dr. Leslie Curtis had mentioned earlier in this forum, what may be seemingly intuitive has to be rigorously studied, and we've decided that we would be randomizing patients to the MSN intervention. And we've obtained buy-in from the hospital team that we've been working with at St. Luke's. And we've had discussions with the IRB, and they believe that even though there is a randomization component, it would be under the rubric of quality improvement, and the randomization would be performed by the MSN once the referrals are sent from the hospital team. Finally, the types of outcomes that we hope to study, and we're hoping to launch this initiative in the near future with our first hospital at St. Luke's. Two sets of outcomes. The first is whether or not the use of the MSN is meeting the needs of patients from a social determinants of health standpoint. Keep in mind that we're going to be randomizing patients, with half the patients being controls and half being intervention patients. We'll assess whether or not food security has been improved in the patients that have received the MSN intervention. We'll assess whether or not transportation access to physician appointments has been improved, as well as rates of making follow-up appointments for their congestive heart failure and their other primary care and specialist appointments. Finally, we're going to study readmission rates at 30 and also 90 days beyond what Medicare is setting as a metric for quality of care. And we're looking at all-cause and heart failure specific readmission rates. I'm going to stop here because I know we have another speaker, but we'll be taking questions in a little while. Thank you so much.
Great. Thank you so much, Dr. Chan. That was great. So any questions, again, can go to the chat box while we're transitioning here between speakers. And now, so you've heard from kind of two of the interventions along the heart failure carousel that we've talked about with the QVIC, and now you'll hear from our third. And so you'll hear from Dr. Mary Benton, who is a cardiovascular outcomes research fellow with KCQVIC and St. Luke's and UMKC, as well as Dr. Mark Patterson, who's an associate professor at UMKC in the School of Pharmacy. And they'll be talking about implementing and evaluating the coordinated payer disease management programs in Kansas City. So the floor is yours.
Thanks, Stacy. I appreciate that. So today, Mark and I are going to talk about the Payer Disease Management Program. And the goals of the program include helping patients manage their heart failure more effectively, developing greater collaborations between payers and hospitals, improving transitions of care for heart failure patients, and reducing heart failure readmissions in the long term. So currently, payers in the region have these disease management programs that can really help our heart failure patients. And typically, these programs are conducted by specialized disease management nurses who connect the patients through a series of phone calls or in-home visits beginning within 48 hours of discharge. And these programs include a variety of really helpful services that can include medication reconciliation, coordination of social determinants of health related services, so healthy meal delivery or transportation to and from doctor's appointments. And depending on the patient's specific insurance and their plan, they can be eligible for free items such as blood pressure cuffs or digital scales that go up to 500 pounds, or even free produce vouchers. And these programs typically follow patients from about 30 to 60 days, but it can be more if that's necessary for the patient. And one of the really key factors is also these disease management nurses. They can help patients develop and set goals for their heart failure self-care, such as monitoring fluids, healthy weight, or reducing sodium, which is also important to trying to keep patients out of the hospital. And while these programs have a lot of really important components, they are vastly underutilized. For example, depending on the disease state, the rates of engagement between payers and patients is about 10 to 40%. And so some of these barriers, they can include insurance companies not having the correct number of patients, patients not wanting to answer 1-800 numbers, patients' lack of knowledge about the disease management programs, or patients getting lost in the phone system if they're trying to call payers back. So what we wanted to do was to develop a process to see if we could improve the connection and the engagement rates between payers and patients, and also improve the communication between hospital nurses and the payer disease management nurses in discussing patients, because currently, that doesn't happen very often. So what we did is we had a series of meetings and we developed these process maps, and we decided where we wanted to see where is the best place to intervene to increase these engagement rates that also minimizes the disruption to the heart failure nurses in the hospital. And what information is the most helpful for the disease management nurses to have when they're working with the patient to try to increase their management of their heart failure. And what's the best way to transmit that information? So what we decided is, what happens is during the normal course of treatment, heart failure nurses assess social determinants of health just during regular intake, and it's usually in the EHR. And they also then find out what is the patient's insurance. And if they qualify, then just before the patient is just, discharged, what they do is they talk to the patient and they alert them and say, hey, listen, there's this really, your payer has this really important program that could really help you manage your heart failure and trying to keep you, out of the hospital. You want to pay attention and, look for it on your phone, or if they call you, to call them back. So once that happens, the patient is discharged, and then the heart failure nurse then emails the payer disease management nurses and says, listen, we've got this patient, they were just discharged. Here's their discharge instructions and any recommendations we have regarding social determinants of health, or any clinical things that we think could help you help them manage their disease more effectively. And so once the payer receives that, then they contact the patient, and hopefully this will lead to increased engagement rates and ideally more patient-centered care.
Great, thank you, Mary, for that great overview. So I'm going to focus now on explaining how we're proposing to evaluate the success of this implementation using the RE-AIM framework, and then using this information to continue to improve the process moving forward. So Dr. Hajaji mentioned the RE-AIM and the CODE-HF, so I'll just briefly go over this. The domains and on the left column. So REACH captures willingness to participate. Effectiveness is how well the intervention worked. Adoption is about organizational components that are supporting the participation in the intervention. Implementation is about the fidelity, the extent to which the intervention is consistently implemented across site settings and patients. And then maintenance is the sustainability in the long term. I think the important thing here is to focus on the right column, where we're proposing some questions and metrics associated with our payer DM project. So for example, how many heart failure patients discharged from the hospital participated in the program? The effectiveness, the second row, is particularly important. Did the connection rates or the callback rates between payers and patients improve over time? That is like a key short-term outcome that's very important to all the stakeholders involved. And also, obviously, were heart failure readmission rates reduced? So here you note that we have kind of a proximal as well as a more distal outcome. Adoption focuses on which components of the disease management program helped participation or reach increase. And then implementation is about the fidelity. So to what extent did the payers or hospitals deviate or adhere to the implementation protocol? And then exploring more how and why. And then maintenance is really looking at the long term of all of those. So our general plan moving forward is we've started this pilot, and we are using really a mixed methods approach to gather data for all these 5 domains. Obviously, we're only in the first 4 at this point, and we're very early on. We plan to tweak the process as we go along. We've already tweaked some of the referral communication that we've learned through our conversations need to be improved, and then ultimately expanding the sites to building a larger study. Next slide. And so we have initiated the pilot project. We start on September 1st with 2 payers on board, Blue Cross Blue Shield, Kansas City, and Humana. And we're also working with St. Luke's Hospital Plaza, specifically 5 different heart failure units on different floors of the hospital. So since inception, we have continued to connect with all stakeholders. This goes back to that important collaboration piece and building trust with our stakeholders. So we've been connecting with them regularly. And most recently, we're communicating by emails, phone calls, conference calls to discuss workflow, process barriers, facilitators, and also starting to tally monthly referral rates, which we will eventually kind of streamline our collection tool there. So the next slide is our plug. We are really seeking to expand this specific initiative, as well as the other 2. I mean, note that this is one of 3. So the CODE-HF and the MSN are the 2, and this is the third of our interventions that we're showcasing in our QVIC. We're seeking to expand this specific initiative to additional regional payers and hospitals in Kansas City. And we really are encouraging payers and hospitals to consider this an opportunity to not only improve their warm handoff between hospitals, patients, and payers, but obviously to improve patient care and reduce heart failure readmissions. And this fits into our overall mission of our QVIC heart failure team and our approach. And so what we offer as a research team, we offer our expertise to our stakeholders to collaborate with you all to design or improve the workflow and to ultimately assist with implementation, and not only assist, but design, run the implementation, and evaluate. And that's what the QVIC research team brings to the table. So next slide, just briefly wanted to acknowledge so far those who we are working with this pilot, our colleagues at Blue Cross Blue Shield and Humana, our colleagues at St. Luke's Hospital Plaza, as well as our QVIC team. And please, we can respond to questions at the end with as we proceed to the question and answer session. So thank you so much.
That's so great. Thank you to all of the QVIC team on presenting the projects that you're implementing. It looks like we have about 5 minutes left, room for a few questions. Is there anyone on that would love to ask their question aloud? Otherwise, I do believe the one we have in the chat box was addressed later in the presentation, but we can talk about it further.
Yeah, hi, this is Aditi again. I have a question. So implementation science, like when we do implementation projects, the payers benefit, the hospital benefits, and the funding could be from the insurance companies or the hospital system or NIH. But if we have funding from let's say insurers, then do we end up limiting our sample to the patients who have that insurance? And that kind of changes the entire project. And I mean, I guess these are logistics of these implementation science projects, and I'm just trying to understand which funding agency to go for which project.
So I guess I can take a stab at that. I think it's a very good question as to sustainability and whether or not the funder can limit the population of patients that may benefit from whatever intervention or quality improvement initiative is being studied. When Mark and Mary were talking about the payer initiative, that's really no cost because it's really trying to better conduct the logistics of connecting patients with payers and their disease management programs post-discharge. And the missing gap has been the communication with patients once they're discharged. As simple a thing as having the right contact information and not having the patients ignore the call, which can be perceived as a spam call if it's coming from a 1-800 or 1-888 number. And our experience in talking with Blue Cross Blue Shield is that they're probably connecting with patients only about 30 to 40% of the time post-discharge when they try to reach the patients, even though they have tremendous resources as well as Humana for their patients in disease management. For the CODE-HF project, the QVIC is really funding the cost of the QVIC team to help operationalize the intervention in the emergency room and working with Cerner and also Epic to translate that at the hospital level. The managed services network is where there is some cost. The MSN does not function in a vacuum. The initial thought from the MSN was that the cost savings from meeting the non-medical needs of patients who have high social determinants of health concerns would pay for itself by reducing readmissions. But I think that they have found that hospitals are very interested and very engaged, but are not necessarily willing, at least for now, to commit the resources for the upfront funding for the MSN. So the MSN in turn has come back and said that we have funding from the Department of Aging, a federal agency, that they will fund 100 MSN slots for us to study rigorously in a randomized way whether or not the intervention actually makes a difference in patients' lives. If we can show that not only does it reduce readmission rates for patients at high risk from an SDH, social determinants of health standpoint, but also save hospitals or payers money, there may be much more interest in terms of the sustainability option, as well as the long-term benefits to all stakeholders involved.
Definitely. And I guess one thing which is related to that is also, it goes back to my previous question about IRB. So if you have the health system involved or the insurance involved, then it's more like a QI. But if you do the same exact project and have, let's say, funding from, for example, NIH, then it becomes a study. And because there's a fine line, and then all the regulatory stuff completely changes. So, I mean, I feel that if we can get the health system or insurance agencies involved in this, there's a lot more benefit, and it's a mutual benefit because we are making patient care better, and then it's also helping them save costs. And I don't know, just to me, it just seems very tricky. Okay, where do I take this project to first?
Sure. No, it's a very good point. And so we've actually had conversations with the teams at St. Luke's and with the IRB at St. Luke's. And the IRB is very interested in thinking through with us, even though it will contain a randomization component for the MSN intervention, that this would be construed as a quality improvement initiative because it's part and parcel of what we do in a routine of daily health management of our patients with heart failure at high risk. And even though there's a randomization component, that it would still be understood as QI, at least as we've had the initial discussions with the IRB. If we get additional funding from the NIH to have a much more expanded study, it will require, and by the way, even though it is construed as a QI, we will obtain informed consent of patients to participate as part of that.
I was just going to add on to that. I think a big distinction is whether or not you're contributing to the generalizable knowledge in a research rigorous way, and then it kind of definitely falls under the traditional research IRB kind of auspices versus when you're conducting quality improvement, whether it be at one institution or across multiple, and helping with those specific care processes that exist. I think that's kind of a way to kind of think through. And you obviously navigate that with individual IRBs, but that's kind of a way to think through where and how IRB status falls. And I guess and at that, I'm now looking at the clock. We are at 1 minute past. I want to be respectful of everyone's so generous time that they've given us today. And we've had such a great lineup of speakers, and thank you to all of you. We really look forward to sharing this recording. It will be on the QVIC website in a couple of days, and then also we'll hopefully see many of you next month at the next forum. So thank you so much.
Thank you very much. I think we should just put in a plug. Anybody who wants to get involved in these projects, Aditi, it's the first time we've sort of seen you, should reach out to us. We would love to include as many providers and researchers and other stakeholders as possible if any of these aspects interest you.
Thank you.
All right. Thank you. Take care. Bye all.